Let's go ahead and here are my disclosures. Here are Dr. Blumenstein's. So when we think about the ocular surface, I always like to point out, what do we normally think about? It's the cornea and conch, right? Is that the first thing that comes to mind when I say ocular surface? Really, it's way more than that. The ocular surface includes the lids and the lashes. It includes the tear film, the goblet cells, the meibomian glands, the accessory lacrimal glands, lacrimal gland itself. And when I evaluate the ocular surface, I like to be very systematic about how I approach it. I like to start and go from outside to in. So I'm going to start by looking at the lids and lashes. Then I'm going to move on to the conjunctiva. I'm going to move on to the cornea. I'm going to look at the tear film. And I like to always take the systematic approach, really, so I don't miss anything. And this all starts with the eyelids and lashes. And I would say, if anything, this has probably been the year of the lids and lashes. I was joking. I think one thing we're going to talk about too is obviously Demodex. I think we should add that as a zodiac sign, the Demodex sign, because we have it so much here. So what exactly do lids and lashes do? So protection, right? When we blink, they help us protect the eyes from getting things into the eyes, shield debris, but they're also intrinsically involved in production of tears. Every time we blink, we spread the tears. But one other thing is they're also highly involved in pumping out of meibum. So when Selena and I were talking today about, the lids being droopy and saggy, that's way more than just a cosmetic concern. When you have that lid laxity, what's happening is you're no longer going to get really optimal pumping of that meibum out of the lids. So not only is it not going to look great, you're not going to have that great a function of the tear film. So let's talk about some diseases of the eyelids. And again, many of these we have touched on. So now if you have questions, it'd be a great time to ask. So when I was first learning about blepharitis, and I would bet many of us had too before, we really were diving into a lot about Demodex. What I think with blepharitis is I think about bacterial blepharitis. Is that similar to you guys? Is that kind of what you would traditionally think of? Yeah. And when I'm looking, I often say when I do ocular surface disease, I'm looking for a single sign for a single condition. And I know that seems like overly simplistic, but the problem about it is all of these things have overlap in the symptoms, because guess what? All of these cause burning, itching, dryness, grittiness. So it's basically worthless to go off of those symptoms. So I try to find the one thing. If I see those symptoms, I try to find one sign or piece of history that's going to help narrow down to what's going on. And when it comes to bacterial blepharitis, that's saponification. And everyone here has seen this, right? You've all seen the bubble bath on the lids. So basically what's going on here is people ask, is this an infection because it's bacterial? It's not a true infection. I call it a pseudo infection, because a true infection is you have an external foreign pathogen that's causing the infection. Whereas for this is normal staph bacteria that we all have, and it's overgrowing and overpopulating. And what happens is you get an abundance of these lipase enzymes. And what they start to do is they start to break down the lipid layer of our tears. And as we blink, it froths it up. And that's how you get these bubbles. So if you see these saponification bubbles, then you know you're going to be having this overgrowth of bacteria. And then over time, what do we get? We get these lid margin changes where we get lid notching and a scalloped appearance. And that's just due to chronic inflammation. But what happens when we get that? Now you're going to start damaging the meibomian gland orifices. And now you're getting into more MGD. And it's just this vicious cycle. And then there we go, Demodex again. So I think at this point, since we talked about it a lot, I want to give you fun facts about Demodex. So my undergrad major was in zoology, so I get to talk about the weird facts here. So we are not the only species that has Demodex mites, but brevis and folliculorum are our two special friends. And does anyone know how we get Demodex mites? Are they contagious? I know these are questions people are like, I don't know. Are they contagious? You tell me. So not in the traditional sense. So the fascinating thing about Demodex mites are you got them from most likely your mom. So what happens is we all have them, and they're ectoparasites. So they actually have done genetic sequencing, and they found the same genetic sequence in offspring and their mother. And it's because these are initially passed from skin to skin contact. And they think, we're like, well, why don't you get them from dad? They think more so you get them from mom because you have more skin to skin contact. Now, again, something most people didn't think we were going to be talking about, but they think it's actually spread from breastfeeding because these mites are found in glandular tissue. And basically, when when you're breastfeeding, that's another area of glandular tissue. So they think that's where there's a lot of transmission. And because you have more skin to skin contact, you can get both mite populations. And what happens is that moms outcompete dads. So even us, if we have, like, from your spouse, for instance, you're going to have a lot of, close contact, but because your resident Demodex mites have really kind of, this is their turf, they're going to fend off the other ones. They're not taking over. They're like, this is mine. So that, I mean, so it's kind of nice. You have this little bond. They still suck, so you got to get rid of them. But at least you kind of feel maybe a twinge of sadness, but they'll say, well, we'll be back. And you're like, well, okay, I'll just do this again here. So as you can see here, you've got these long kind of cylindrical buildups of debris, which we call collarettes. And the thing is, too, I also like to say that at this point, I have an unhealthy collection of photos of collarettes. And I'm probably on a list somewhere because, like, why does this guy have all these weird eyelash pictures? And this case right here is a really good one because you can see these very prominently. I'm a big fan of often showing you the worst, most obvious case because then you can learn to look for the subtle cases. So this was a patient who came in and he's in his 30s. And a lot of people ask, like, well, do you treat if they're asymptomatic? And this is my philosophy for this because he told me he wasn't having any trouble at all. If you look at those, you're probably like, I don't know, how are you not feeling anything? But I don't like to talk patients into having a problem, and they don't like it either. So what I do is I say I take a planting a seed approach. I'm like, okay, so we all have these bacteria. It's normal, but they can overgrow and they can cause some problems. They can cause itching and irritation of the lids and lashes. And I'm happy to hear you're not having that now. But if you are, next time just let me know because we have these treatments available. Now, I will say this. A lot of patients, when you tell them they have mites on their eyes, they'll be like, oh my God, get them off immediately. I want them gone. So they're not going to have trouble with just getting the treatment. So that's going to be, but some, and again, this is shocker, there's a male-female divide here, where a lot of my female patients are like, nope, get rid of them. I want no mites. Or the men are kind of like, I'm doing okay, because they're stubborn like they always are. But I plant that seed and I say, if you do have trouble next time, let me know. I came back and I saw him the next time, and unprompted, mind you, I didn't bring it up yet. He's like, you remember how you talked to me about those mites and everything's like, yeah, I think I want to do something about them. So they will come back. That's what I say. So don't worry. Some people are like, well, if you don't treat them right away, or they never, no, they'll come back because inevitably once you get them to look, most of the time they're just not looking for the signs and symptoms. So if you identify them, they're going to come to them on their own. Again, that's just my approach, and that tends to work really, really well. Yeah.
They get bloody like that along with the collarette. Are you thinking more beautified and does extend the work?
Excellent question. So one of the big things with this, they're like, what other differentials can you have? And though it's very rare, you can, I mean, do you guys all remember talking about getting lice in the lids? Yeah, it's something we really talk about at school, and then you rarely see it afterwards. If you've ever seen what lice can do, it can look very, very similar. Here's the difference: blood. Lice feed on blood. So if you see what looks like a bloody collarette, then you know you're dealing with lice. As for that, I don't believe it's been particularly studied in lice, so that would be an interesting thing to see. But yeah, something you're probably not going to see, but if it's bloody, then you actually know you're dealing with lice. So that's a great question. And then again, this kind of just shows you where they live. You got the two species. You got the follicular, which are larger. They're in your lash follicles. And then you have brevis, and they're going to be in the meibomian glands. And it's actually easy to remember because I always think F for follicular, and then the B meibomian. I think B with brevis for that. And again, they have the life cycle for this. So here's the other interesting time for fun fact number 2. So we traditionally have thought that they don't have a fully formed digestive system, and this actually goes into a lot of evolutionary biology and things with parasites and like being a symbiote and things like that. But basically, there is a very interesting study that got picked up by a lot of news outlets before about Demodex, which was funny. And do you know what the big discovery was? They might have an anus. So that was breaking news all the time. They're like, you have these mites on your eyes, and they have an anus. I'm like, ooh, tell me more. So basically, and it's funny, in the paper, they actually have a picture of the supposed mite anus. And I'm like, wow, look at that. That's the glamour shot right there. But here's the big question. Is it functional? We don't know. So it's likely that it's now just a residual, basically, organ. It's that they still have it, but it's not functional. But I basically say this either way. Whether it's vomit or feces, you don't want it on your eye. So Either way, not a great thing to have. So, this is great for dinner conversation. Talk to your friends about it, bring it up. They'll be really impressed. And again, collarettes are the pathognomonic sign. I love this because it's so rare that often we get this nice one-to-one where we have one sign, we see it, and we know what we're dealing with. So one thing I've actually seen a lot too is when you see this, you can diagnose it with confidence. A lot of people are like, okay, is this Demodex blepharitis? I'm not sure. They're kind of hesitant to say, but if you see this, you know what you're dealing with. So you can be very confident in your diagnosis. And again, it's easy. Have them look down. So this is another fun little pearl here. So with your patients for dermatochalasis, where does it hang down over? Right over the base of the lashes. So you might take a look and you're like, oh, no collarettes, great. But then you lift up on those suckers and it's hiding. So I could say, always check in the folds, which is a fun thing to say too. I'm like, yeah, your folds are just creeping with these parasites. I'm like, oh my God, get rid of them now. So now let's talk about allergies. So this is something we all basically see day in and day out, but sometimes oh yeah.
Question. If Demodex causes blepharitis in 69% of cases, how do you decide to give lotilaner?
So for me, if I see Demodex, I'm going to prescribe it. It's very simple that if they have that and I see the collarettes, you basically follow what's the most logical course of action. That's what I do. If I see that they have the collarettes, then I know they have the Demodex. I'm going to do that. So here's another thing to mention about that. That's another thing to bring up is people are like, well, what if it's bacterial? What if it's Demodex? And I say, ¿por qué no los dos? Why can it not be both? Because oftentimes it is. And the reason for that is because the Demodex are dirty little critters. And they actually have bacteria that live inside them and on their bodies. So they can actually act as a vector for bacterial blepharitis. So I've seen people who have collarettes and saponification. So then those are patients I really want to treat because not only are the Demodex creating a problem, but they've overpopulated so much, they're bringing their friends along. So I will always try to get to more of the root cause, which lotilaner can be very helpful for. So then for allergic disease here, a question I commonly get is dry eye can cause itching, right? And so can allergy. How do you know which is which, especially when they often are concomitant? So one thing is you can look for the signs, which you can get this papillary reaction. That's one of the easiest things to do. And then in really kind of more acute cases, you can get this kind of stringy, ropey discharge. And then sometimes you'll get flaking and scaling of the skin that's more chronic. But one of the easiest ways to screen too is you ask them how their eyes feel after they rub their eyes. So if you have a dry patient who has itching and they rub their eyes, afterwards they're going to say, my eyes feel pretty good because you've just mechanically stimulated tearing. Whereas if they rub their eyes and they have the allergic response, it's going to itch more because they've just mechanically degranulated more histamine. So that's a really quick, easy way to delineate the two if you need to. And then MGD, just like dry eye itself, this is multifactorial. There are so many different causes of MGD, but it's very easy to diagnose. Just press in those glands, see what comes out, look if the oil is turbid, look at everything like that. This can be involved with Demodex because the little guys burrow down in there. There can be so many causes for this. So this is something once you see it, you're going to want to address this, but talk to your patient about that because this can be, again, associated with screen time. Again, if we're not properly blinking, this is a good time to kind of talk about blink mechanics. So when we blink, typically we blink between 16 and 20 times per minute when we're looking at distance. But when we look at something up close, that can drop to even 4 or less. And the reason for this goes back to how our eyes developed. Our ancestors were primarily hunter-gatherers, so most of their visual world was looking for predator and prey. And they would look at something up close, but it was for a short period of time. Now, our brains they know that for holding something up close, it has to be important information, or why would we be holding it so close to our face? So we're going to kind of have a lower blink rate because it'd be really hard for us to look at something up close if we're constantly blinking, right? The problem with this is our ancestors might look at something up close for a few minutes. We're looking at things up close for hours and hours on end. So our visual system didn't develop for this. So what happens is we want to blink, but we don't want to obstruct our vision. So we start to do these partial blinks. And partial blinks, even if you look at the literature, so a reduced blink rate isn't great, but the literature shows that incomplete blinks are even worse. And again, this goes back to the mechanism of basically meibum secretion. When the lids come together all the way and they touch, that's when you're actually going to get that secretion of meibum. Versus when we're doing these partial blinks, the meibum is going to build up, and not get released. So now you're going to have more of that stagnant meibum. along with all these other concomitant conditions, it can get basically clogged even more. And now you're going to get MGD from that component to things. So that's why even now still it's a basic thing and you don't hear it as much. I still tell patients to do plank exercises. They might not do it a whole lot, but I still do encourage them because I just think it's a good behavior to do. And then this is the other one we've kind of been hitting on, which is mechanical eyelid issues. These are massively, wildly underdiagnosed. One of the biggest things I see is lid laxity. And lid laxity is primarily due to aging. And you can see here, so I want you to look at two things. What's the obvious is you can see the staining, right? Where should the lower lid's position naturally be? Should you be able to see the inferior sclera? No. So every time you see that, I document inferior scleral show because that lets me know that this patient has laxity and now they're very high chance they're going to have some degree of exposure. And that shows me this. And that's why I loved what Selena said about the scaffolding. And sometimes it's not even the lid. It's all of the structures in the upper cheekbone are no longer there to hold it up. And gravity just pulls that down. So that's a major one we're going to see for many patients. Because, yeah, you can get lag ophthalmos from a lot of other things, from a nerve palsy, things of that nature. But a lot of the time you're going to see it is from natural aging. And then our favorite good old styes, as everyone likes to call them. They come in, I've got a stye. So what does that mean? So really that's just a generic term. And typically the patient is referring that they have a chalazion or a hordeolum. But I also know sometimes it gets a little bit confusing when you see them. You're kind of like, okay, what am I dealing with here? Is the hordeolum? Is it the chalazion? An easy way to remember it is, at least the etiology, is that the chalazion is inflammatory. It's not infectious. A hordeolum is infectious. That's the easiest way to think about it. A hordeolum will normally be really, really sensitive to touch. Both can be, but it tends to be a little bit more sensitive. You're going to get a little bit more heat. You seem to get some heat off of that. And sometimes you get more of that pussy appearance to it. Again, there's some overlap here. And this is just what I often see. You can get a preseptal cellulitis with both, but the hordeolum is more likely for that to happen in my experience with that. And they respond. The thing is, so this is something too that I always kind of harp on, and people can disagree with this. I am going to prescribe an oral antibiotic for these. A lot of the people will try to use a topical drop, but my thing is here is, how's that drop getting in there? It's not. That's the big thing. It's not. You need to use an oral because that's what's going to get in there. I know some people are a little bit hesitant to use orals if they don't use it routinely, but that's something that I do and that responds really well. I know some people also, they don't like to prescribe antibiotics, but again, for me, it makes sense mechanistically and it's going to get in there. So I'm going to prescribe that. I'm also going to still tell them for like a chalazion, I want them to do warm compresses with a massage on it. And then IPL can be a great treatment for this as well. I've been doing that to success. People often ask me how many treatments I do for that. It can vary. The fresher you treat it, often the better it responds. But I've had anywhere from 1 to 8 sessions. And even then, I will tell you, though it works well, there are still some cases where it's been there for a while, where I've had to send it out to get cut out. But it's nice if you can do something that's a little bit less invasive and might even spare some more damage to the meibomian glands. Yes?
Tried it with Bluffex or anything like that. Do you feel like sometimes they go onto that and what?
Like the actual lesion, the chalazion? Yeah. So manual debridement can be good for some patients. So the biggest thing is, okay, we've all kind of been taught you never want to squeeze these, right? Because it can potentially spread. But if you do see it coming to a head, I've done that before where I don't squeeze, but I'll gently debride that and it will kind of naturally get the flow stimulated right when you see it was that. So I have seen that respond. That's basically, you just don't want to really crank on it. But if you feel like it's coming to a head, you can, especially if there seems to be some junk building there, you can debride that and that can be helpful. Yes.
Do you have suggestions on oral antibiotics?
I do. So typically for this, if it's a hordeolum and they don't, obviously, you always want to ask about allergies. That's a big one for this. I personally like augmentin. People go with their different strokes for different folks. But for a hordeolum, it's just that soft tissue things respond very well to augmentin. So I'll use augmentin. If they have an allergy to that, I'll also use doxy. Doxy works really well. So those are the two I primarily use. For chalazion, though, obviously I'm going to use a bit more of the doxy because it does have a bit more of that anti-inflammatory component that you get as well. So those are kind of my two go-tos.
And then a follow-up to that, do you prefer oral antibiotics or IPL as the first line treatment for hordeola?
Depends on the patient. I will offer both. Some patients I know either they're very sensitive to antibiotics and they don't respond well. It's a great alternative. Other patients will want it for one reason or the other. And there are patients I treat with both. Some people are like, I don't care. I want this gone, hit it hard with everything. So kind of dealer's choice on this. I'm very big on bringing the patient into the decision-making process. It is my job to tell you our options, and together we will decide what to do. So yes. Yeah, so this is a great question. So the question is, when you have these patients who have basically had a chalazion for months, in this case 3 months, they've been on doxy, what dose do you use? So the first thing I tell people, again, if you haven't necessarily had a lot of experience with this, I was just very fortunate. The way my residency was set up was every day of the week I was with a different subspecialty. So I got a chance to really kind of see how each of the subspecialties approach things. And when I was with my oculoplastics doctor, like I would see they would keep people on this for months on that. 3 months is not even close to the longest. So I think some people get the idea of like long-term being like 1 month. No, I've seen patients who've been on it for 8, 9 months, a year, even with that, and that specialty. Now, granted, that was a time before IPL had really picked up. So I've been definitely in that case would want to do IPL. But I normally go lower dose at that point. And what I mean by low dose, so the magic number for doxycycline is 40 milligrams. And the reason for that is that 40 milligrams and below, it no longer has antimicrobial properties. It still retains its anti-inflammatory properties, but when you're worried about all the side effects you get with, long-term antibiotic use, you're less worried about those at that threshold. Now, here's the thing, though. There is no generic doxycycline that comes in 40 milligrams. It comes in 20. So what I'll do a lot of times is I'll prescribe just the 20 and have them take both at once. Or even the 20 can be helpful if they're longer term. There is no set determined dosing for this. So long term, I like to titrate down to like the lowest that can be effective. So a lot of times I'll do 40 or 20, sometimes every day, sometimes once every 3 days, once a week. Again, I like to kind of talk to the patient about that, but I keep them at that lower dose for sure. Zpac, excellent question. Yeah, so a Zpac can actually work. There's a study that showed Zpacs can also be very effective with just one Zpac because it actually has a prolonged effect without. The problem with me with the Zpac is if it's very stubborn, the Zpac is still at that antimicrobial threshold. So that's why I don't want to keep putting them on Zpac after Zpac after Zpac, purely because of that threshold. But it is a great alternative for that. That's the only consideration I have. I will use azithromycin. It can be very helpful for that. Yeah, so the question was, do I get patients having the GI upset from the low dose? Not nearly as many. And that's one of the reasons I do. I still tell them, so the big thing when you're using doxycycline, we have to be smart about using it. If you have a female patient of reproductive age, always tell them about pregnancy. Are you planning on becoming pregnant? Are you trying to be pregnant? Might you be pregnant right now? Are you breastfeeding? Because those are situations where you cannot use doxycycline. You also can't use it on younger children. You see different things, but really anyone below 13, you shouldn't be using it on. So you have to make sure you do this. And I also always document that I discuss with a patient, especially if it is a young female patient. I said, discuss potential this, patient voiced understanding of that, because that's the thing. If we're going to be doing this, we have to be very aware of that. I often do the low one and I tell them about stomach upset. So that's why I often recommend they take it with food. I also make sure that you want to avoid calcium with it because that can interfere with absorption for that. But that's why I like the lower dose too. And the other thing is you can get sun sensitivity. You get that photosensitivity, you're a bit more likely to burn. So out here for us, definitely a discussion to have in really sunny environments. But yeah, this is all for me. When I'm using doxy, I am making sure we check off every one of those boxes. And actually my techs are really good. They know if they come in and a patient has a lid lesion like this, they know to ask right away. They're like, they'll come in, yep, patient not pregnant, patient not breastfeeding, things like that, because those are things you can't miss. That's the big thing with that. You cannot miss those things. Also, my girlfriend is an OB-GYN resident, and she would kick my butt if I missed those things. So perfect segue into rosacea, because this is another condition I'm sure you're all aware that doxycycline is routinely used, again, for the anti-inflammatory effects for this. I'll tell you, when you get really bad ocular rosacea, this is a tough thing to treat. Because do you know what the number one, so even though this can cause a lot of burning and irritation, can you take a stab at what their number one complaint is? Redness, persistent redness. My eyes are red all the time. And the reason for that, so you can see on the lid right here, do you see how heavy that telangiectasia is? But then also look at the conj. So do you see kind of how you have the thicker vessels? Look at the really skinny, kind of stringy vessels. Those are telangiectatic vessels. And here's the thing about those. They're perpetually dilated. So we know that we have dynamic size to our vessels over time. You know they're going to constrict or going to expand depending on need. These guys are always dilated. And that's one of the reasons why you have that chronic red appearance. So this is really tough to manage. And patients are often very self-conscious about this. And I openly tell them the hardest thing that's going to be to treat about your condition is going to be your redness. IPL is a fantastic choice for this, but I still tell them it's going to help the redness, but it will not perfectly get rid of it. Now, this is another nuanced discussion that you're going to have is with the use of brimonidine, with low-dose brimonidine with Lumify, because these patients are going to love it from the cosmetic effect, but you also have to explain, you know, we're kind of masking this. You know what I mean? This isn't necessarily treating the underlying condition. That being said, you're going to have some doctors who are like, oh my gosh, don't use, you know, don't use Lumify. It can be irritating with a patient like this. I will say this about my rosacea patients. And again, this is my clinical experience. When I use the drop, some people will use it and they say it does feel a little bit irritating, a little bit drying. When I use it in my rosacea patients, they normally say my eyes feel better. And the reason for that is because it's the one thing that can get these perpetually dilated telangiectatic vessels to shrink down. So you're basically cutting off that nozzle of inflammation there. So that's a major factor for some of these patients. Obviously, they like the cosmetic appearance, but the way I use this is for my patients. If I say I have a problem with redness, I keep a bottle in my office, I put one drop in, and I even let it sit to the end of the exam. So before they've even seen the cosmetic effects, so I know it's not psychological, they say, yeah, that drop is making my eyes feel a little bit better. And then they look at the mirror and they see it and they normally say, holy something or other, my eyes are actually white. So again, it's one of those things. I'm very pragmatic to my approach. And if they're worried about that, I tell them, you know, it's not fixing the problem, but it can help with the cosmetics. Yeah.
Couple questions on IPL. Is IPL contraindicated for patients with melasma?
So like all fun things, the answer is it depends what paper you read. So melasma, basically, if you've never seen it before, it's these kind of brown patches on the skin. And they're primarily driven by hormonal changes, which is the big thing for this. And when you do IPL, one of the big things you want to talk about is a potential for hyperpigmentation of skin lesions. So what I tell my patients with melasma is, so you have these spots that are called melasma, and if you see, sometimes they can get darker with IPL use, but there are also papers where they use IPL to treat melasma. So you're like, okay, well, what do I go with? And mine is educate the patient, have a conversation, see what they want. That being said, I have a patient who has really significant melasma and really bad dry eye. And here's the thing, you can treat melasma. So she literally said, nope, let's just do the IPL series and I'll just take care of the melasma afterwards. So again, just let your patient know, make sure, because you know, there's the whole saying that if you say it ahead of time, it's expected. If you say it afterwards, it's your problem. So I'm very proactive. I try to like head off any potential concern at the beginning so they're not worried. But that's really the answer to that. It sometimes can be helpful. Yeah, just have that conversation with the patient.
Great. What about, can you do IPL on patients that have tattoo eyeliner?
Yes, but you have to be careful. This is the thing, because it's actually used for tattoo removal, and I've heard it's incredibly painful because, again, IPL works off of pigment absorption. So tattoos are very, very dense pigment. So you can, but what you do is you want to stay at least 2 millimeters away from it. The same like when you're treating on the eyelids, you always have to have eye protection. So I use laser grade corneal shields that are metallic. And when I do that, I make sure I'm 2 millimeters from the lash line, or at least 2 millimeters from the tattooed eyeliner. You can do it. You just have to be cautious that you don't overlap. So we've already kind of hit some of this, where what's the impact that this has on our patients? So all of these conditions are going to have an impact on our tear film stability. So you're going to have all of the dry eye signs and symptoms that we all talk about. You're going to have inflammation. You're going to, over time, get damage that can lead to scarring. And the big thing we often think about scarring is, so our body uses scar tissue basically as just a filler. Once something's damaged, It's just putting it in there. Scar tissue is not functional. That's the big thing. Like I always remember, I like to go back to our basic biology things with this. So scarring, a lot of times, like, oh yeah, cosmetically it doesn't look good, but that means we've lost functional tissue and basically just put in filler. So the thing too is fluctuating vision. I will do a quick little side tangent on fluctuating vision here with ocular surface disease. One thing I've found, which can get a little bit frustrating sometimes, is I feel like when it comes to visual complaints, dry eyes become our new punt diagnosis. We're like, oh, their vision's blurry, and you see they have a little bit of dryness. We're like, it's going to be the dryness. Except in extreme cases of like really confluent SBK, I'll tell you, dry eye is not going to drop you worse than 20/40. Like, so I mean, I've had people come in, they're 2200, and they're like, oh yeah, dry eyes. It's not going to do that. The easiest way to screen for this is to say, does your vision improve when you blink? Does it change when you blink? If the answer is yes, then you know there's at least a dryness component. If they say my vision stays blurry, again, outside of cases of super confluent SBK, then it's going to be another cause, and you have to figure out what that cause is. I once had a patient who was referred to me for fluctuating visual complaints, and it ended up being an optic nerve tumor. So yeah, so don't use this as a quick way to get that patient who has a super slow refraction out of your chair, because you can definitely miss things with this. So that's my little soapbox, that make sure that you're addressing all the visual complaints for this. And then again, with the lids, when you have that lid laxity, you're going to have impaired protection. You're going to get that exposure of the cornea. You're going to get the abnormal blinking, which is going to, again, impair your meibum secretion there. And then again, there's the cosmetic concerns that we've talked about today. You get your redness, you're going to get eyelash loss. And I have a lot of patients, and what does this do? This drives them to get things like trying those growth serums that have the prostaglandins, and then they just get stuck in this loop. So we really want to try to address the root cause of these problems. So a lot of these too we've talked about here, but let's talk a bit about some of the traditional lid hygiene products that we have. So we've talked about for like, when it comes for Demodex, you're going to use a lot of Laner. We've talked about that a lot. Ivermectin can be used, but I don't like to use it mainly because you do have a threat when it's oral of neurotoxicity. And I don't think many of us are treating onchocerciasis or river blindness. So I don't think that's going to be a huge thing for that, because that's actually what it works for, and it works for it really well. But again, not something that we deal with really. And then for our traditional hygiene, we kind of have the main ones here. So baby shampoo. Do you know what baby shampoo is good for? Baby hair. That's what it should be used for. And the reason for that is because it's just not formulated for the use we're using this for. I know if you look at a lot of old reference guides, like, someone might go to like an urgent care that has a reference manual from 1972 that says like, oh yes, use baby shampoo for blepharitis. The problem with baby shampoo is it strips oil, and we naturally want to have some oil on our skin, right? It's protective. So if you use it too much, you're going to start stripping away the oil from the lids, and they're going to become irritated. They're going to become cracked. They get inflamed. If that baby shampoo gets onto the ocular surface, into the tear film, it's going to start breaking down that lipid layer, because that's what it does. And I've used the term, I've coined it, I have seen baby shampoo blepharitis. And what that is I've had patients who come in, and they're normally very good about their hygiene, and they're like, my eyes are killing me. And I look, and the skin is like cracked. I've seen it bleeding before. Their eyes are so red and inflamed. And I ask them what they do. They're like, well, every day I use my baby shampoo twice a day. And if my lids get really irritated, I wash them again. So in this vicious cycle of just stripping away the oil and everything. So recommend one of our other things for this. Again, baby shampoo is from a time when we didn't have anything better. So hypochlorous acid, I'm a big fan of that. So the way I describe it to a patient is hypochlorous acid is actually made by our own immune cells as an antimicrobial agent. So it's very gentle. It works really, really well. I normally have patients do it twice a day. Tea tree oil, we kind of discussed earlier today too. So tea tree oil, there's some studies that are like, okay, in a petri dish, if you expose it to a super high concentration over time, it can damage meibomian gland cells. But at really low concentrations, it's likely not going to be a major concern. Just talk to your patient about that. You might have them only use it for a short course and then take a break, because it can be irritating, especially at higher concentrations. And then okra-based cleansers are really good options for patients with sensitive skin. And I'll use all of these treatments. And warm compresses, they're primarily for comfort. Again, this is from a time when we were trying our best to treat things. They can help with meibomian gland dysfunction, but they're not really going to keep the maintained heat they need to do any real kind of fundamental melting of the meibum in the glands, but they can help a little bit, and should definitely use caution with ocular rosacea because it can make the inflammation worse. And honestly, cool compresses can be very helpful for a patient. I think they're underutilized, so that's a great thing to add for a patient who has, they're like, yeah, my lid's burn, they're irritated, that can be helpful. And then omega-3 fatty acid supplementation. I am a very big fan of this, but here's the thing. Do not send your patient out to get it on their own, because the laws of nature and the universe dictate they will get the cheapest product possible. It's just the nature of the beast. So basically here, you want to get the magic formula for this is that you needs to have a 3-to-1 EPA to DHA ratio. It needs to be at least 2 grams, has to be reesterified, triglyceride based. I see all the pens clicking, so I'll do it again here for this. So you want a reesterified triglyceride based omega-3 supplement, and the EPA to DHA ratio needs to at least be 3-to-1, and you need 2 combined grams of EPA and DHA minimum. And the reason for that is because that's actually the formulation that was clinically studied to help with dry eye, because someone always brings up the DREAM study, and I like to use that as a study that was terribly designed. Like if I would do a study design thing, I'm like, here's not what to do. They wanted to make it real life, and by doing that, it didn't tell us anything. So that's one of the big things, because it didn't use that formulation. So that's kind of the criteria I use, and I've had really good success with that. Yes. So you can actually do this. So for this, the one I often use is personally, there's a lot of good ones out there, but I use DE3. And the reason why, and so you can actually, so it's 3 capsules. You can take all 3 at once. Some people just have a hard time kind of digesting that. So you can spread it out throughout the day, but I personally take it myself too, and I take all 3 at once. So I just tell that to the patient. So and the reason why I have to take so many is just because you need to get these high doses. So that's really hard to get that dose into a single capsule. And that's why it's normally multiple capsules, but you can take that all at once. Yeah. Okay, yeah. So this is where it gets really interesting. So Kim Friedman is amazing. I worked with her and she does really good lectures on this. I mean, you can do an entire lecture on this. In fact, I think she basically she did one for this. And this comes down to why I said you need to have that triglyceride-based reesterified formulation, because they really think a lot of the blood thinning effects and things like that are actually associated with ethyl esters. So basically what happens when they make fish oil, it's actually funny. I tell all of my dry patients this exact thing, why I choose this fish oil. And if I would have asked 5-year-old me and say, hey, you're going to talk about fish oil every single day of your life, I'm like, what do I do when I grow up? So basically when they make a fish oil supplement, they get the oil from the fish, but it's naturally going to contain impurities. So they have to purify it and they distill it. And in the product, it ends up in what's called an ethyl ester formulation. And that's what a lot of the store brands are, because they're very cheap to manufacture. But the problem is they believe that with that ethyl ester compound, that's what has more of that blood thinning effect. But at the same time, I'm very big on, again, I want the patient to be comfortable with it. So I explain the science to them. But if they're hesitant, I'm going to tell them, I want you to be comfortable with this so you can, do what your gut tells you. However, this is the science behind it.
Blood sugar?
Not that I'm aware of for that. But again, a lot of times too, and then Kim, at this point, she's been doing it so much. She's like, she doesn't worry too much with that. But if a patient is hesitant, I'm like, you can also talk to your cardiologist about it. But honestly, a lot of times they don't necessarily know the difference too. But I always just want to make sure everyone's on board with this. Yeah. So yeah, so DE3, it's made by a company called PRN. But that's the formulation is called DE3. Yeah, so it's a good one, but there are a lot of good ones out there too. That's just personally the one that I use. And in-office treatments, again, we've talked about a lot today about IPL, different microblepharoid exfoliation procedures. These ones are just really good options to have to just kind of get that ocular surface cleaned. I say, especially if someone wants to start a dry clinic and they're like, kind of building on a budget and they want to bring in a device, but they don't necessarily yet have the resources to get something like IPL or something like this. These devices are great starts for this. They're normally low barrier to entry. Pretty much you can talk to any patient when you see them. What I would say, especially if you want to do an education, I'm big on anterior seg photography. So if you see lid debris or buildup, you can show them the picture and you can say, hey, we have these procedures we can do here in the office. I know a lot of doctors really like to use Zest too. I do a lot of new lids. So new lids is one where there's a new lids pro, which is an office version. And then they have an at-home version called new lids that a patient can use kind of in between. So I've used those before. Those are really good. I'm sure all of you are familiar with BlefX as well. That was kind of one of the first ones we've had. An interesting thing up here too. Have you guys ever heard of Rinsada yet? So Rinsada is a new device, and it's really interesting. So basically what it is it's basically kind of like a lid averter. So it's got the hook and it's attached to a syringe. And so you put it under the lid, and what it does is it basically have these channels tunneled in, and when you press the syringe, and it just does a high, basically velocity saline rinse that can get into the fornices. So you're basically just rinsing the ocular surface. And at first when I heard about it, I'm like, oh, okay, well, okay, that's interesting. But then the more I thought about it, it made a lot of sense because when we have patients with ocular surface disease, we know that they have elevated inflammatory factors on the ocular surface and in the tear film. And what's the whole point of like our mucin layer is to hold the tear film onto the ocular surface, right? So it's supposed to hold it on there. So if you have a lot of these inflammatory factors, they're going to stick. So what you essentially can do with this, it made a lot of sense to me. You're basically doing that high velocity and you're just going to reset it. You're going to rinse all of that off. And I did a trial with one of my patients. She has really bad Sjogren syndrome. And I did one eye just to see. And the next day she's like, I can like feel a difference between the two eyes. Again, I'm not going to say this is going to solve everything, but I do think it's something that can give your patient quick kind of relief afterwards. So it'll be interesting. Again, it's just kind of started use and I'm just getting some experience with it. But I do think it's a very interesting idea. Can I kind of reset the ocular surface, the tear film? Then we have our thermal pulsation and expression procedure. Oh, yeah. So I do both. So normally what I'll do is I'll prescribe the Xdemvy. And the question is, am I doing Newlids or a microblepharoid exfoliation procedure before prescribing Xdemvy? And what I'm doing is I'm prescribing it, and then I'm doing that in the meantime. Because like kind of Selena mentioned too, those collarettes are pro-inflammatory. So I'm like, let me just get this cleaned off, give us a head start, and then we'll treat the underlying cause. So I use those in conjunction, and then I'll have them do lid hygiene afterwards for maintenance. So that's kind of like, the idea of kind of like treating and extending the effects of it. And then, like I said, we've talked a lot about IPL, great option, does multiple things in a single treatment. And then radio frequency works really well as kind of targeted heating. The other thing is, too, we know one of the limitations that we have for IPL is that darker skin types, we're not able to do it just because it absorbs too much energy and you have the risk of skin damage and burns. Whereas with radio frequency, you can do it on all skin types. So that's a great treatment option to have. And radio frequency to me is a really interesting thing because when I first heard about it, I didn't necessarily see where it could fit. Honestly, I'm like, okay. But I talked to a lot of doctors, especially like in Canada, they've been utilizing radio frequency for a while and they saw good results. So I'm like, okay, that's good. And then we have more research to it. But really, to me, it's a really kind of elegant idea when you think about it. So what radio frequency does is it's using radio waves to basically generate heat, but it can do it in a very targeted way. So for the device I have, it does a protocol. It goes 3 minutes at a low frequency, so it can actually penetrate a little bit more deeply, and it can really kind of concentrate the heat at the meibomian glands. And the second 3 minutes uses a higher frequency, so it's going to be targeting the heat at the lid skin itself, more of that collagen. So that's how you're getting that bulking of the collagen. And to me, that's a 1-2 punch because what you're doing now is you're melting the meibum and then you're potentially helping that lid tone basically by tightening up the skin. You can get a better blink and help get the secretion of the oil. So that one's kind of become my go-to procedure. I pair it with IPL typically. And then after I do 4 treatments of each of those. And then after I do the 4th treatment of radio frequency, then I will do a manual gland expression. And I've seen, it's been doing that for about 4 months now and I've seen good results. So back to allergy here. So all these are things we're very familiar with, but the one I kind of want to draw your attention to is ectoin. Have any of you guys ever heard of ectoin before? Okay, so I hadn't either, but when I heard about it, I'm interested, and if I don't know something, like, okay, let's figure this out. So ectoin is actually a molecule that is made by extremophilic bacteria typically. So we were all taught about like the bacteria that live in sulfur springs or hot springs or things like that. So they live in very harsh environments. So one of the things that they produce is called ectoin. And what this molecule does is it actually operates by a principle called preferential exclusion, which I had never heard before. But basically, the ectoin molecule is just super attracted to water, super attracted to it. So what happens is if it's around water molecules, it pulls them in really tight around it. So when you put it onto the ocular surface, it's going to pull those water molecules in very tightly. And basically, this sounds weird. I'm like, okay, this sounds crazy, but it's in the literature. It basically creates a hydration or a water shield. So by reducing the space between the water molecules, it's harder for environmental irritants. So think like allergens, pollen, to actually get to the ocular surface and actually elicit that allergic response. So I've had a lot of success for this. Right now, the only one that I know of, it's called Allegro. Optase Allegro is the drop right now that uses it. And I've had good results with it. The other way that I often will utilize this is, how many of you have had what I call a breakthrough allergy, where you have them on like olapatadine, like Pataday, and it works well, but they say by the end of the day, even like once daily, because I really like Pataday once a day extra strength, because it works really well. But I've had some that are like, yeah, but in the afternoon, I'm getting itching again. I love to pair them together. So I'll say like, okay, use your Pataday in the morning, and then in the afternoon, I want you to use the Allegro. And then also because you're getting two different mechanisms. You're getting that antihistamine effect, you're getting that mast cell stabilization, but you're also getting this preferential exclusion. So I've had a lot of success using it in that way.
Question with the ectoin, is that safe for people then that are breastfeeding or pregnant?
To my knowledge, yes. I'd have to double check that, but to my knowledge, it's pretty inert. And the other nice thing is the drop, it's also formulated where it's like a preservative-free drop. So it can also work really well with dryness in general. So I kind of tell patients like a combo drop for that. But to my knowledge, it's very inert. Might be something better to look at for that. But I'll say, at least to my knowledge, I don't think there's a huge contraindication there.
And can you also touch upon LLLT?
Yes. So I have some colleagues who are doing it. Personally, right now, I don't do it just because basically the wavelengths of light produced by that are similar to IPL, like they're included in the same range. So for me, when I'm doing IPL procedures, it kind of seems a bit redundant to me. That being said, I do know some people will use that for patients who are darker skin types because you can use it. But just for me, it's not a huge thing right now. There is data for it. I would like to see more data personally. And you could ask me maybe in like 3 or 5 years, I might say, yeah, that's a great option. Something that I'm not currently doing, but I do know plenty of my colleagues who do and use it well. So definitely an option for sure.
And kind of piggybacking off of that, how do you feel about traditional red light therapy with the red bulbs close to the face without goggles?
Just be careful. I just tell people, I mean, again, humans have an amazing way of hurting themselves. We are so good at hurting ourselves. So anytime they start asking a question like that, I'm like, I do not like where this is headed at all. So I normally would say, I would say, it might not be dangerous, but you don't want to find out. So again, that's for me. I would say, when in doubt, be cautious. That would be my answer to that. And then tacrolimus, how many? Oh, yeah. Mm-hmm. It would probably be similar because it's the same thing because you're dealing with bacteria, because a lot of times you'll use like intense light like that to do that. So might maybe some bacteria more resilient, but it should be the same principle. Exactly. And that's why for us it's probably not the best. Exactly. Because if you're covering the lids, that's where you have to use something else, because again, you don't want to risk it with high intensity lights around the eye. So yeah, I would not be using, for the most part, like that type of high intensity light to try to sterilize the lids, just because the risk involved with that. So then how many of you have used tacrolimus before? Yeah, a few. So this was something I picked up in my residency. This works really well for people who have a lot of atopic lids, the lids that are itchy, flaky, and dry. So a lot of these patients will respond well, obviously, to steroids, but you don't want to use a topical steroid on the lids for a long period of time, because it's already the thinnest skin in the body, and it can thin even more, and it can cause changes to pigmentation. So tacrolimus can achieve a lot of the same things without those side effects. So I'll use tacrolimus ointment on those patients. Typically, I'll dose it twice a day. And then over time, it's funny, they'll almost kind of taper it themselves, and then they kind of use it when they need it. But that's a really good alternative. And I think we had a really good conversation about this already, the doxycycline. So I think we hit that very well. The one other thing I always bring up is azithromycin. So you can get topical azithromycin, and it actually can be used to help with MGD and lid inflammation. So what you can do for that is you can actually have the patient use that and kind of rub it on their lid and lashes, and have them do it every single night for about 2 weeks. And then you can kind of do it every other day. There's different protocols. The doctor I worked with in my residency, he absolutely loved doing this, and there were good results. So that's another thing you can do, especially if a patient can't tolerate orals. This is a good thing to consider. And then we talked about exposure here. So I kind of, the stepwise approach I like to take when it comes to dealing with night exposure, I like to kind of go from easiest to a bit more, not invasive, but a little bit more involved. I'll typically start with like a nighttime gel because they're less blurring. See how a patient does with that. If they don't do with a gel, then I'll often move on to an ointment because they're thicker, but they can cause a little bit of blur. And then if they're still having trouble, I'm a big fan of the moisture chamber goggles. Like the eye seals are great because basically they're a soft silicone. They make a seal around the eyes. Patients even kind of sweat underneath them. So it's almost like making a moisture chamber underneath. And the only challenge patients have to that is can they keep them on their eyes while they sleep? Some will wake up and they're like, oh, it's across the room every single time. But most patients, like if they work for them, they work well. And I'm like, oh, they're also, if you've ever seen them, they're super sexy. So yeah, that's something you can do. And then during the daytime, you can send them to someone like Steph, who will actually fit the scleral lenses, because my rule of thumb is if it doesn't flex in my fingers, I'm not going to touch that lens. So thank you all for fitting those who are, and those can work really well. And then moisture chamber specs, those are the ones, if you've seen them, they have kind of like a soft silicone gasket around the side. Those are really good for our patients who have that kind of environmental sensitivity.